Thank you, Manos and Manos. This is a wonderful Athens meeting. So I'm going to talk today on the natural history and progression of the rotator cuff tear. So historically, we have found out that 30 to 85% rotator cuff tears usually heal, and many of them, they don't heal because of degenerative and regenerative potential, which is reduced at the tendon junction because of a lack of apoptosis. So natural history of rotator cuff tear can be viewed from certain points, first starting with the epidemiology, the anatomical variation, patient profile, biomechanical and biological factors, and radiological variations, along with clinical and progression with conflicts of the range of motions. So epidemiologically, it has been the most important topic because shoulder pain is the third most cause of orthopedic surgeon and a patient visitation. And increase in the age has shown that there is an increased propensity towards the rotator cuff tear, especially when we talk about the symptomatic versus asymptomatic tear. Asymptomatic partial thickness usually are hidden lesions, and sometimes the patient may come with the advanced stage rather than coming at early to the clinician. So the prevalence of rotator cuff in general population has been studied by various researchers. One of them is Dr. Yamamoto, and they found out that between 70 to 80 age is the most prevalent time when you can get the rotator cuff tear, and some of them could be really asymptomatic. So incidence prevalence has suggested that true incidence of partial thickness tear remains unknown, and there are various studies, including the bursal-sided, intratendinous, and articular-sided tears, where they found out that surprisingly, you may not see what you see in your clinical practice as the percentage of rotator cuff tear which is gone undiagnosed. Why it goes undiagnosed? Because if you do the anatomical variations of this natural progression of the disease, you'll find out that footprint is almost 14 millimeter width. But the undersurface and bursal surface tear usually tend to mask those disease, especially the bursal surface is very easy to diagnose, but the partial articular surface tear sometimes can go unnoticed unless they land up in a full thickness tear. The disease of rotator cuff has been viewed in biological fashion also to evaluate the biology of healing of the rotator cuff onto the tendinous junction. And they found out that the bursal surface tear start with the healing instead of the partial articular surface tear tendons. The patient profile also plays a very important role as far as the natural history progression is concerned. Whenever you see a patient with a dedicated and high demands, especially the elderly patient, then you'll get this kind of tears which can go unnoticed, and physiologically they can progress into a major tear. So this paper has been from Stefani Gumano, and he's found out that smaller tears in female population, especially in the elderly ladies, has gone undiagnosed without any clinical evidence. There are certain comorbidities like hypertension, diabetes, overweight, and smoking, which can lead to early failures or early failures of the rotator cuff tear repair, or it can increase the proposition for the progression of the rotator cuff tear. What about traumatic versus non-traumatic? Sometimes when you get a traumatic tears, especially in the younger individual, you can have a good propensity towards the healing whenever you do a debridement, and then you can do a simple tear, simple rotator cuff repair as you do in your clinical practice with the help of suture anchors, as you can see here, and you can still get a better result with this kind of tears. What other factors which can lead to early propagation of tear and then the progression is hypoxia, oxidative matters, changing collagen subtypes, especially because of the tendon degeneration, and tissue-reduced collagen synthesis, and extracellular matrix degeneration. This is all biomechanical studies has shown that down-regulation of this collagen genesis can lead to early failure or the progression of the tear in case it is a partial tear or a smaller tears. Why it happens? Because of the vivid vascularity of the distal cuff tears. If you see, this is a wonderful picture by Stefano Gumina, and where he's shown the vascularity in distal supraspinatus tendon is very, very vicarious. And it's very difficult to predict the healing part of the tendon when you have a vicarious vascular supply into the distal tendon. Is the genetic behavior is different in the form of, does the every cuff behaves in a different way? Yesterday I spoke to Giovanni and I asked him whether the cuff in the younger population and older population behaves in a different way. He said no. The genetic proposition and genetic changes has shown that every cuff will behave in a different way, and together it can lead to almost 80% of total hereditary index if we have a familial disease of rotator cuff which can be regenerated. The biomechanical studies has shown the supraspinatus tendon has got very good attachment, but once it leads to a partial tear, the potentially predisposing to a complete tear, because the pattern of remaining intact fibers can get altered. In various studies, they have shown that this altered pattern of the undersurface tear can lead to early progression of the disease. Spontaneous healing of the supraspinatus tendon has been noted, especially in the sheep models, but the human studies are not to be yet disease found. The natural history of asymptomatic tear is again a very important topic because it depends on the location of the tear initiation, the enlargement, and ultimately a symptomatic development of the tear, which can lead to early progression of the tear into this. Now, we'll go across the Swiss experience. Yesterday, I got this slide from Dr. Alexander Castagna, and he told me about this Swiss experience where they have studied, after 42 months, they diagnosed these patients with MRI, and they followed them for 42 months, and they found out that many of these sizes of this tear were increased in the limited period without any symptoms. So they may not be symptomatic, but there is a progression of the tear which has led to early failures. So is there any method we can prognosticate the rotator cuff tear, which is been seen in early in your clinical practice? This is my own patient. 2015, this patient had a partial tear, and then in 2019, he came back with a massive retracted rotator cuff tear. So progression has been studied by many researchers, and they found out that repeated MRI studies, they got the retraction of the tendon, which starts from distal intermediate, and they get retracted beyond glenoid, and it's very difficult to get this back to the tuberosities. Especially, this is a significant tear, and there is a high enlargement rate whenever you see the progression, which is starting from the distal supraspinatus tendon, especially from the anterior part of the tendon, rather than the posterior part of the tendon. So what is the last stage of the natural progression of the rotator cuff is usually the fatty infiltration and full retraction of the tear into the glenohumeral joint. So there has been studied which shown that fatty infiltration is associated with the high failure rate of the rotator cuff repairs. The glenohumeral kinematics usually changes after the fatty infiltration, and this has led to a critical tear, which is around 175 millimeters square, and you can get a light retraction up to 1 centimeter whenever you see a high critical shoulder angle, which has been propagated by Christian Gerber. What does usually we see in our clinical practice? When we see such patients in clinical practice, they usually present with pseudoparalysis, with superior subluxation of humeral head and attempted anterior elevation. So you can see this patient, they are unable to hyperabduct or hyperforward flex shoulder, and they can lead to early pseudoparalysis-like symptoms. Hornblower sign usually positive if it is associated fatigue degeneration, or maybe negative. Especially the patients are completely delineated when they see this kind of disease, and they are completely crippled, because the loss of external rotation is the most important aspect whenever we see this kind of the shoulder pathology. The imaging signs of irritability, especially in chronic shoulder, whenever we see any kind of X-rays, please try to see the acrohumeral distance along with the critical shoulder angle, so that you can propagate and you can prognosticate which rotator cuff is going to land up in a complete tear or the non-healing of the rotator cuff tear. Impingement is one of the causes which has been proposed by, since years it has been proposed, but sometimes when we do a subacromial decompression, we have found out the biological options and biological channels open better way when we consider the impingement and acromioplasty whenever we are planning a surgical intervention. But impingement is one of the causes which can lead to early rotator cuff and progression of the tear. The effect of tendon tear on the muscle is very, very important. As you see, on your left is the full thickness tear, on your right is a partial surface tear, and whenever you are treating a partial surface tear along with the impingement, you will always see a bursal surface tear. So never finish your rotator cuff partial surface tear unless you are going to do a subacromial diagnostic round, and then only you can claim that it is a just partial surface tear. Loss of active forward flexion and the Popeye sign because of bicep tendon disease can lead to early failures and early degeneration of the shoulder. And from here, the degenerative process in glenohumeral joint starts, along with the severe wasting of and atrophy of the shoulder muscles and periscapular muscles, which is evident on this Hamada grading as well as the Gutelier grading. So Dr. Gutelier had classified this as stage 1, stage 2, depending on the loss of muscle tendon into the Y view of the scapula. And this can lead to early failure of your rotator cuff and disease. Measuring the muscle and the tendon retraction is very, very important when you are planning to prognosticate the rotator cuff repair and the healing of the rotator cuff. If you have a loss of tendon, it is very difficult to get this loss of tendon, and you can go back to this pre-injury status of the rotator cuff. So one has to understand the natural progression of this disease may not be predictable, as we always see, and predictability value of this rotator cuff diagnostic techniques is very, very difficult. So what I believe is strongly that tendon healing, when moderately degenerated, is regardless of sutures or non-operative or operative. Age and cuff tear size are important whenever you are prognosticating any tear. Biology may contribute to the healing process sometimes, but at larger tear, usually it is more mandatory to have a good biological healing. And some techniques favor the ischemia. In my opinion, you should avoid them, like double row repair or the other techniques. Thank you.